this third webinar in our special NTB webinar series dedicated to advancing the implementation of the World Health Organization multisectoral accountability framework to NTB or MAF-TB as you well know it. These series of webinars are organized jointly by the World Health Organization in close collaboration with the TB Europe Coalition. And the series serves as an interactive platform for countries and partners to exchange experiences, share best practices, and discuss practical approaches to operationalizing the multisectoral accountability framework at national, regional, and global levels. So this current webinar that we are having today is focused on driving cross-sector collaboration to deliver people-centered TB care for migrants and refugees. And we're very happy that we will be able, through this webinar, to spotlight concrete actions countries and partners are ensuring to make sure that TB services for migrants and refugee populations are accessible, equitable, and tailored to their unique needs. So we have a distinguished lineup of speakers, and I'm very pleased to introduce the moderator of the session, Ms. Yulia Kalancha, who heads the TB Europe Coalition, and she will moderate this webinar and take us through. Over to you, Yulia.
Thank you so much, dear Monica. Hello, dear colleagues, and thank you for joining us for the third webinar in our series on implementing and operationalizing the WHO multisectoral accountability framework to NTB. So as Monica said, my name is Yulia Kalancha, and I'm the Executive Director of the TB Europe Coalition, and I have a pleasure to moderate today's event. Our webinar is available in 3 languages, so English, French, and Russian. For the best listening experience, please select your preferred language channel using the interpretation function and mute the original audio. So step-by-step instruction should be already available in the chat. And today's event is dedicated to collaboration across sectors to ensure the people-centered TB care for migrants and refugees. And over the next 2.5 hours, we will look at a very practical country and partner experience on how to make TB screening, prevention, diagnosis, and treatment for migrants and refugees population accessible, equitable, and tailored to their specific needs. And I wish us all a productive discussion, and to keep the webinar running smoothly, may I kindly ask all participants to keep their microphones muted when not speaking, and to refrain from sharing their screens. And the slides are accessible in 3 languages. You can choose which language to view in the screen to show bar at the top of your interface at the toolbar. So basically, you should see to view the presentation in English. You should select the presentation in English. To view the presentation in French, you should choose presentation in French. And to view the presentation in Russia, you should select the presentation in Russia. You can already find this instruction in the chat as well, but we will repeat them further as well. And with this, it's my great pleasure to hand the floor to Dr. Hannah Monica Diaz, cross-cutting lead WHO Department for HIV, TB, hepatitis, and STIs, who will set the stage by speaking about advancing the global multisectoral response to address TB among refugees and migrants. Monica, please, the floor is yours.
Thank you so much, Yulia. Let me quickly... Okay. Let's go to my slide set, please. I'm very pleased to set the stage on for this webinar. If we can move to the next slide, please. Sorry, let's go to the previous slide. It wasn't visible for me. All right, so the focus of my presentation is going to be on advancing the global multisectoral response to address TB among refugees and migrants. And we know that this is a critical issue. And you can see this in the next slide, please, where again, I have colleagues here from the International Organization of Migration and the UN High Commission of Refugees, UNHCR, who will also speak about this data, which actually comes from their sources. But as you know, we are in the midst of an unprecedented global crisis affecting billions of people worldwide. Over a billion people have migrated or have been forcibly displaced. By mid 2025, it was approximately 117 million people who were forcibly displaced as a result of persecution, conflict, violence, or human rights violations. By mid 2024, we estimate that there were 304 million international migrants. And of course, social, economic, structural, and political factors faced by migrants and refugees increase their vulnerabilities. And I will explain in the next slide a little bit more about the issues they face. So if we can go to the next slide, please. Um, yeah, so what factors put migrants and refugees at risk? As you know well, the pathway is quite tough for refugees and migrants. They often face issues like congested and poor living conditions, combined with poor health, nutritional status as well, especially when you look at the acute phase of refugee displacement, especially in the case of refugees. There's often a loss to follow up. This may include difficulty in tracking existing people with TB among the newly arrived refugee population, for instance, or even among migrants. Access to medicines, especially among refugee populations, is not always that straightforward. It may be interrupted in certain refugee hosting areas, for example, especially during an acute phase of an emergency. And then there are constrained resources. Funding always remains an issue for migrants and refugees, including coverage by national health insurance or social protection. The next slide, please. Now, we do have the good news is we have key commitments which do address TB in which do prioritize addressing TB in refugees and migrants, and this includes the NTB strategy and its three pillars, including the first pillar on integrated patient-centered care and prevention. We have the Sustainable Development Goals, the UN high-level meeting on TB that happened in 2023. Again, that's critical. And then on the side of the refugee and migrant crisis, so from TB to the other side, there is the Global Compact on Refugees, and the Global Compact for Safe, Orderly, and Regular Migration, again set by the United Nations. And WHO has a global action plan on promoting the health of refugees and migrants. So we do have comprehensive commitments that can help drive the response. Let's go to the next slide. If we do a deep dive into the most recent commitment of the UN high-level meeting on TB that took place in 2023, and if you look into it, you will see that the impact on refugees and migrants has been well highlighted through the commitments, with a call to action to really address the issues surrounding, the situation of refugees and migrants and making sure that they are able to access care. Next slide, please. And based on all of this, you see that we need, it's not a straightforward response. It's not just a TB response or a health response that is required to address TB among migrants and refugees. We need a comprehensive, multisectoral response because the factors that affect these populations are are multisectoral from social and demographic, as I explained, from poor living conditions. They face stigma, discrimination, poor working conditions. They live in poverty, for instance. They do face several comorbidities, including the risk of co-infection with other diseases like HIV, diabetes, immunosuppressive conditions, lung conditions due to air pollution and other factors. Undernutrition, which is one of the biggest drivers of the TB epidemic, smoking, etc. And then the structural issues, such as the lack of access to healthcare, the lack of access to social protection, the income inequality, and then, of course, further compounded by further natural or man-made disasters, conflict, etc. So, therefore, a really core multi-sectoral response is required. And this is why, if we go to the next slide, WHO's multi-sectoral accountability framework is very critical when we are looking at addressing TB among migrants and refugees. So we really need to catalyze the framework to make sure that the different sectors that play a role in refugee or migrant health are engaged. And I've given here a very quick overview. These are some examples, and country by country, of course, it can vary. For example, of course, the Ministry of Health would be involved in the TB response for providing access to medical care, public health surveillance, etc. But you would need, for instance, in certain settings, the Interior or Home Affairs Ministry or sector to look at issues like legal status, asylum, reception centers, the state of healthcare there. You would need to collaborate with the Social Affairs Ministry or sector to look at welfare, social protection, housing support. You would look at the labor sector and look at the engagement of that sector for migrants for safe work conditions, migrant worker health. Housing is another sector for a safe living environment. Education sector will be critical to look at schooling, language support, health literacy. The justice sector to make sure that their human rights are protected and they're protected from discrimination. You would look at engaging the foreign affairs sector for coordination because it's going to be a cross-regional, inter-regional, international, cross-country effort. The finance sector, of course, to make sure there's funding and budgeting, and women, children, or family sector or ministry to make sure that vulnerable groups are protected. Let's go ahead, please. And when you look especially at, for example, so when you look at the multisectoral accountability framework, of course, we talk about, bringing together different sectors, but it's also important to bring together different UN agencies. And we see this very much in a refugee crisis, in a refugee response, for instance. There is a UN cluster response to humanitarian emergencies, and you see that it's critical to also bring together the different UN agencies which work together with relevant sectors. For example, UNHCR for refugee protection, IOM, both UNHCR and IOM are here in this webinar, and they will be covering it, as well as MSF, for example, who would be working on the ground in the camps with the refugees, with different migrants. You would look at involving UNICEF when it comes to looking at nutrition or looking at children, for instance, the World Food Programme for nutrition, food security, along with FAO. WHO, of course, would be involved in health. So it really, IFRC is another good example of an agency that is quite involved and quite engaged when you're looking at a humanitarian response. So it's really about bringing ministries together, bringing key multilateral agencies together, partners, civil society, everyone around the table to address the needs of migrants and refugees. Next slide, please. So now when you look ahead, now WHO, we have as part of the multisectoral accountability framework, a collaborative, multi-stakeholder and multisectoral platform in place. And many of the agencies I mentioned are part of this. And issues such as this, such as addressing TB among refugees and migrants, are in the spotlight, and we do work together to look at these cross-sectoral issues. Please go ahead. And then I would like to also highlight some guidance documents that we have. We've developed several policy documents over the year. In 2022, we released an interagency field guide among refugees and other populations in humanitarian settings with UNHCR and CDC. And then we've developed more recently, launched just last year at the World Innovation Summit for Health in Doha, a wish report, a special report looking at innovative solutions for the elimination of TB among refugees and migrants, which outlines key solutions. And of course, we have through our regional offices very specific policy guidance documents, such as in the Eastern Mediterranean region or the European region specifically, where they do have very targeted interventions for these regions. So it's not just something that's led by headquarters, but it's also being led by our regional offices at WHO and our country offices. Now, if you go to the next slide, please. So I'd like to put a spotlight on the WISH report, and if you can click again. Now, this report was developed by WHO and the World Innovation Summit on Health, the WISH Foundation, in collaboration with UNHCR, IOM, and other key partners, including MSF, etc., which features basically it outlines innovative approaches, policy actions that can contribute to eliminating TB in refugees and migrants. It's well aligned with all of the key commitments that I mentioned earlier and our guidance documents. And it has urgent calls to action to address the dire impact of TB on migrant and refugee health. It does highlight the respect for the principle of non-discrimination and human rights, and it does advocate for multi-sectoral, multi-level, and transnational approaches through the engagement of affected communities, civil society, UN agencies, local and international partners. So this is one of our latest documents with key recommendations that we urge countries to take up, especially those in the midst of a refugee and migrant crisis. Let's go to the next slide, please. And this report has 10 recommendations, 10 policy options. And as I said, it's aligned with all of our strategies. It talks about mobilizing high-level leadership, strong political support, ensuring that there are adequate resources for the response. The next slide, please. And the next slide, yes. And we ensuring that, sorry, the previous slide. Ensuring that national health policies are sensitive to refugees and migrants, that there are legislative frameworks in place. Also, that there are mechanisms for coordination, dialogue to facilitate a multi-sectoral response. Also promoting interregional actions such as cross-border collaboration, regional concilia, information sharing. The sixth recommendation or policy option is on leveraging the technical guidance and support from WHO and other UN agencies to ensure that refugees and migrants benefit from universal health coverage. The next one, please. And promote, of course, the meaningful engagement of civil society, NGOs, and representatives of refugees and migrants, because this is critical when you're looking at taking forward a response that's centered on the health of refugees and migrants. So having the affected refugees and migrants as part of the response or the solution will be critical. It's important to improve the capacity of surveillance and monitoring, and also enhancing disaggregation of data so we have a better picture of the impact on refugees and migrants, so that there can be more prioritized, targeted interventions that can be taken forward. Ensuring that research that highlights the barriers to accessing TB services and is part is promoted well, and that the research or the new tools are translated rapidly to also benefit refugees and migrants. And then the last one is to continue review and monitoring progress made on this and keeping it as a top priority. So this in a snapshot are the 10 policy options that are highlighted in this document, in this special report that WHO is working across with the other UN agencies and partners to take forward. We hope to report back on this next year. And the report also, if you go to the next slide, features case studies, um, which basically there are 7 case studies well featured here. And you will hear from one of the case studies where we have Dr. Muna, who will speak from Qatar. We also have case studies from the Middle East, Africa, from the PAHO region, from the Americas, from Southeast Asia, looking, of course, at Bangladesh, and we have Dr. Akram, who will speak on, the Cox's Bazar, the Rohingya camps, and then we have also, Poland, and we have Joanna here from MSF who will speak to this. So we have also case studies well featured in this report, and you will hear more about this and the multisectoral response that's been implemented across several settings to address the needs of refugees and migrants. Can we go to the next slide, please? So looking ahead, again, in conclusion, just to say that refugees and migrants face unique barriers. They are in a very exacerbated situation and they require our support and our need to prioritize them. A multisectoral response, as I have mentioned through my presentation, is key and offers the opportunity to build more resilient, inclusive, and people-centered systems for these vulnerable populations. We need to strengthen the partnerships, especially across our international community, to ensure that displacement and migration does not determine health outcomes. And together, we can definitely work to ensure an inclusive, coordinated response that truly leaves no one behind. Thank you very much.
Dear Monica, thank you very much for outlining the global approaches to organizing and advancing a multisectoral response to tuberculosis among refugees and migrants. And your presentation clearly showed how timely this approach are and how well they respond to the current challenges in addressing TB in the context of increasing migration and displacement. As our webinar are designed to be interactive space for dialogue, I would now like to invite all participants to share a reflection or ask Monica any question. I saw that there are some comments in the chat that people liked the presentation and the recommendation they saw. So may I kindly ask my colleagues to stop screen sharing for this part. And dear participants, please use the opportunity to clarify any points, raise comments, or briefly share your experience. If you would like to speak, please raise your hand in the platform and we will give you the floor, or you can send a comment in the chat. Are there any comments, dear colleagues? I believe, Monica, that your presentation was super clear so that people have no question, but I see that you may see as well in the comment section. So people are commenting on the recommendation. So this comment recommendation clearly show how civil society engagement, better data system, and reducing access barriers can improve TB care for refugees. You see the comments. Oh, I see, Stefan. We were missing you. Please, the floor is yours.
Thank you, Julia. Hi, Monica. That was great presentation. My name is Stephen, the implementing public audience. I would like to get maybe
Dear colleagues, am I the only one who do not hear in the English channel?
clarification if this policy
No, you're
guidelines
not
are
alone. I also cannot hear.
Okay. Steven, we can't hear you. Can you?
Can you hear
I
me
believe
now?
there is an internet.
What about now? Am I audible?
You're audible now. Yes, you are, Steve.
Yes, but Steve, you should be in the
Okay.
English channel so that people can hear you properly and there is a translation. Dear colleagues, can you switch into the English channel, Steve?
Okay. What about
We've lost you, Steven.
am I now audible in all languages?
Yeah, now we can hear you.
Okay, thank you. Thank you very much, Monica. I was saying my name is Stephen Nanguva Shikoli. I coordinate network of TB
But there
champions
is
in
nothing
Kenya.
happening in
We
the
are
English channel if
co-implementers
people are
with
in
Combat
English.
DRTB and UNITAID. So my question or clarification to Monica is, currently, I've seen what you've presented and critical action point. My question is, does it address the unregistered migrants? Because we know we have some refugees or that are not registered who sometimes have challenges in access to important critical TB services. So does that policy also address that population, or it only focuses on registered migrants? Thank you.
Thanks, Stephen. Thanks for your question as always, and thank you for your support. No, these policy actions basically call for action across all refugees and migrants, whether registered or unregistered. In fact, it is about enabling access to all and ensure no one is left behind. So there are key steps if you go through the document, and we'll put the documents in the text so that you can go through it. And we do have multiple agencies who work on this as well to ensure that everyone is covered. So this is something that is not happening fully at the moment, of course, but this is the call or the push to countries to recognize and provide care for all refugees and migrants, irrespective of their status.
Thank you so much, Monica. Thank you so much, Steven. We have two other hands. Vaim Gili, please, the floor is yours. And then our honorable speaker, Maheshwari. Vaim Gili.
Vama? Vama
Vama.
Jalil?
Monica, maybe this is the issue.
Oh, okay. Thank you so much. This is Vamachele from Eswatini. I'm actually representing the miners, the migrant miners that has worked in South African mines. But I really appreciate this presentation, and as well as the approaches that you guys decided to take forward, especially ensuring that migrants are actually well cared of. We are aware that there is universal health coverage, but even though there is an existence of universal health coverage, you will find that some of the migrants are actually identified by ID or the country of destination ID, and then they deny them access to such services, especially we are talking on TB people. We know for sure that we've got migrant truck drivers who transport ore around Africa and even in other countries. So I'm very happy because you started with the issue recognizing the cross-border challenges, especially when it comes to TB. We don't want anybody to be lost to follow up. We don't want anybody to not follow his treatment requirements, which is ensure that they drink their tablets. And we want to ensure that they are also socially protected in the countries where they are actually the country of destination. So what is very key is that whenever we move with this kind of initiative, we make sure that the TB people are centered from the discussion to planning and to implementation to ensure that we don't leave anyone behind. We also looking at the Catholic approach, because I think we have to expand our boundaries from this committee to ensure that we also have a say at the Stop TB partnership to also help us to ensure we shape our program in such a way that a global forum on migration and development delivers healthy migrants around the globe. And also we look at there is a high call of screening for TB, and as well as the issue around food nutrition. We are aware that most of our migrants move around, and only to find out they are denied access to such a very important thing, social protection, in their countries of destination, which is also key. And the gender rights and stigma and discrimination is part of the things that also affect the migrant populations who move within the different countries and different regions, which is very key. So then the focus will also be expanded within those boundaries. And also the issue around linking to care. I'm very happy with this policy document, which you guys are actually formulating, and I'm happy also to be part of it. Thank you.
Thank you so much, Vama. In fact, that's not really a question, but more of a commentary highlighting key aspects, especially when you look at migration, and completely agree with you. Indeed, there are several cross-border transnational issues which require special focus, especially when you look at high-risk populations like minors or truck drivers, as you rightly pointed out. And we've seen that there are some very good case studies and examples across South Africa, Lesotho, for example, or when you look at India, there are a few examples on truck driver programs led by ILO, for example. And yes, we are also moving forward on undernutrition. This was the focus, one of the focus of our last webinar, also on social protection. These are really critical issues that we think need to be brought to the forefront. And as we are accelerating towards the last mile on ending TB, it's all about a multisectoral response and making sure no one is left behind, and making sure that we are able to bring all sectors, all hands on deck with civil society, leading and showing the way, affected communities showing the way, because you understand the situation on the ground the strongest, to help us, have this people-centered response. So thank you very much for that commentary from yourself, Vama. Thanks.
Thank you so much, Vama.
Thanks, Julia. Sorry.
Thank you, Julia. Thank you, colleagues. And thank you, Dr. Hannah, for your presentation. I think some of my presentation later will echo and touch on what you've already mentioned. But I just wanted to not ask a question here, but also just reflect on what the other colleagues have said and just add in. As you know, the UN-80 reform as well as the humanitarian reset is happening. So on top of those broader, systems that are working together, we also have a major funding decline. And I really feel that this is the moment for us to check in regularly. How far are we implementing all these partnership and multisectoral approaches? Because we should not lose the effort and the work that we are doing together. Great guidances, but we need to follow through. And I feel that that's what one of the things that we need to check in. And it's great that you're having this webinar follow through after the union conference. And I think this we need to have periodically to have a check-in. What are we doing, what we're not able to do, and how we're going to navigate that system, and as well as how we are all working, in different agencies to bring our approach in trying to engage and advocate for inclusion of refugees and migrants into the national system and into the national TB frameworks, because we don't want to exclude them, because we understand that the humanitarian sector has been suffering from shocks and outbreaks and displacement, if you already put, but I think the current shocks have accelerated, and we also need to be mindful that we can actually have an engagement with the governments to look at how we want to better include them. And I think it's the right thing to do, and how to have that conversation. And please, we need to keep that conversation going, because I think that's where it's important when it comes to implementation. I just wanted to put that out there, because I think that's where we need to strengthen the partnership. Thank you.
Thanks so much, Maheshwari. Appreciate that input and call for action. And yes, I didn't flag this in my presentation, but this is a time of extreme crisis, not just for the humanitarian response, for the health response as a whole. And yeah, with these immense funding cuts, and now more than ever, we need to join forces, especially for these populations who are most at risk. So thank you for that very strong response, Maheshwari.
Yeah,
Julia,
thank
back
you
to
so
you.
much, Maheshwari, for your strong point, as Monica mentioned. So as further we are discussing, the more hands we have, the more comments in the chat we have as well, with very interesting and deep questions. So I'm really sorry if I'm pronouncing your name not really correctly. Salome, would you like to address your questions or comment?
Yeah, thank you, thank you. I came in a bit late though, but up to where I found the presentation, my concern or my maybe clarification that I need. When it comes to policy, they work mostly for a country. And I am looking at the scenario where the migrant is moving maybe from Botswana to Zimbabwe, and they have to be on their anti-TB drugs. And in that policy, do we have where this patient can carry their entire package? Is your treatment the same as in my country? Because in my country, we have the 6 months treatment. And on that note, you find one is expected to go back to the clinic or else to the facility to pick their medications. This can be done either on a weekly, on a monthly, or on a quarterly basis. So does the policy include having the migrant or the refugee have their package as a whole, the 6 months treatment or the 9 months treatment or the 1 year treatment? So what does the policy indicate? Thank you. And if it is not there, maybe to add, if it is not there, can we have such a docket whereby this migrant can have the medication wherever they are and whenever they shall be moving, such that we do not have to switch from Kenya, Uganda, Botswana, Zimbabwe, and the likes? Thank you.
Thanks so much, Salome. It's a very good question, and this is very country specific and very context specific. So it depends on the country, it depends on the region. But what the policy advises is that we put in place measures where there is continuity of care between countries as a migrant or a refugee passes between countries, that there are arrangements made so that they are able to continue to be on treatment. So this is something that has been prioritized. And I think you will also hear a bit more, in the panel discussion, where you will hear how other countries or other agencies are helping with this to make sure that there are no treatment disruptions. But this is definitely something that we are encouraging and putting in place. Thank you.
Thank you so much, Monica. And as Monica mentioned, and you already heard from Maheshwari, and also you can see from the response of our ELSA speaker, John Lodomirska, that you will hear a lot of the question that you are asking, a lot of answers in the presentation of our speakers. So, dear colleagues, we need to wrap up with this session, but Tariro, please... the last question, and then Monica will respond to all the questions in the chat. So she will just answer it in the chat directly. Tarira,
Okay,
please.
thank you. Yeah, thank you so much, and also I thank you, my colleague Vama and so forth. So we did a TB mining regional initiative, and as SADC, there is a cross-border system that was installed by SADC to capture TB people, because there's a lot of movement around SADC and so forth. But the challenge is the system is within the Ministry of Health. And as the civil society implementing partners, we are not sure of the indicators that speaks to us. And also I hear the issue of nutrition, which is very important. So I think this platform and what we've presented is the best place so that we interrogate that CBRI is there for the 14 countries. But to make use of it as civil society and our indicators and whether the issue of nutrition is there, I'm not we are not sure. Then the other issue is in terms of medicines and so forth. We don't use same medicines. Yes, it's 6 months, but we use different reagents across that and so forth. And artisanal miners, they are illegal. They are not in our national strategic plans or in our policies. But SADC is to come up with some protocols so that because for public health, everyone should access medicine. So there are the SADC protocols which now pushes even the ministries of health to include them in their strategic plans, and even as we move towards GC8 for Global Fund, for those who are recipient of Global Fund, they're going to be part of the other KVP in TB. But we really need to come up and help us as well. How can we make a use of that CBR reference system? And it's entirely for TB. Thank you so much. Over.
Thank you so much, Teriro, for sharing information on SADC. And I mean, these are the important case studies, and you've kind of already highlighted the need for a cross-sectoral response, especially with the engagement of civil society. And, we are happy to collaborate with you and work with you. We have all the policies, the indicators in place. What is important is the implementation of these policies and guidelines. And civil society is going to be a key partner, of course, with governments, UN agencies, and others on the ground. But definitely what you have highlighted again is the role also of civil society in enabling the response. So this is something that we can work together.
So, dear Monica, dear colleagues, thank you very much for this rich and thoughtful discussion. Thank you for your active participation. And as I mentioned, Monica will respond to those questions in the chat directly. But after the panel discussion, which we will move to shortly, we will have another Q&A segment where we can continue our interactive exchange. So it's important. And for now, I would like to invite everyone, if possible, to turn on your camera so that we can take a group photos as a momentum of this webinar. And as there are many of us today, it will take my colleagues a little time to capture screenshots of all the Zoom pages. So dear colleagues, can you stop spotlighting me and make the general view? Yes, thank you so much. So in the meantime, let's smile to each other, wave to our colleagues we haven't seen for a while, and enjoy this moment of being together in one virtual room. So I'm encouraging my colleagues to let us know when you have done the screenshots. It's great to see a lot of colleagues, a lot of faces that we are not unfortunately able to see in person, but at least virtually we can see each other and smile, wave. Alia, Vlada, or someone can tell me, are we fine with screenshots?
Yes, thank you.
Thank you very much. Thank you very much. You're all, of course, you're encouraged to stay with your camera on, but if you feel more comfortable without, it's very fine as well. And as usually, we will share the group photo and all materials from today's webinar, including speaker's presentation in 3 languages and the video recording with interpretation on WHO and TB Europe Coalition platform after the event. And we will now move to 5 conscious and informative presentation in our spotlight panel, Putting People First, Multisectoral Solution for People-Centered TB Services for Migrants and Refugees. So just a quick reminder, you can post your questions as you did, as some colleagues already did, to the speakers in the chat at any time during their presentation, indicating who the question is for, and we will then return to this question and take verbal interventions during the Q&A session after the panel. For those participants who just recently joined the meeting, if you would like to follow the slides in your preferred language, please select the relevant screens in the screen to the show bar on the top of your Zoom window, and detailed instructions are already available in the chat now as well. And if you experience any difficulties, please just write in the chat and our team will be happy to assist. Just a gentle reminder to our speakers, each of you have 15 minutes, so please keep an eye on the timer and speak at the please modest pace so that our interpreters can provide high quality simultaneous translation. So please do not rush. So it's now my great pleasure to hand the floor to the first speaker of our panel, Maheshwari P. Murugai, a Public Health Officer, UNHCR Geneva. Maheshwari will speak about the work of the UN Refugee Agency in TB prevention and care within its mandate to protect the rights and well-being of refugees and displaced population. So, dear Maheshwari, the floor is yours. Please, when you need to move to another slide, just say next slide and my colleagues will switch it. Thank you so much, and your time has started. Thank you.
Thank you so much, Julia, and hello, colleagues. Very pleased to be here and to be part of this discussion. It's already kicking off a lot of discussions, but I can see a lively energy in the webinar, although we are joining virtually. So today from UNHCR, I'm Maheshwari, Public Health Officer, and I'd like to sort of zoom in on the context of displacement and also share our collaborative partnership and how we took a specific people-centered or community-centered TB care for migrant, in this case, refugees, in spotlighting in one of the regions that we work in. So if you can move on to the next slide, please. So here is just a snapshot of what displacement looks right now. Dr. Hannah has already spoken a little bit about it in her earlier presentation, but I just thought this might be a little bit more visual. Yes, there are over 117 million people displaced, and that's at least about 1 in every 70 people on Earth. And out of these numbers, 71% of the refugees are hosted in low and middle income countries. And these are also countries that have weaker health systems, that are mired in conflict, a lot of social unrest, poverty and socioeconomic strife. And so these are some of the areas that refugees, countries that are hosting refugees, big burden of refugees, but there are also countries that are also part of the burden of the TB. Next slide, please. So as I mentioned earlier, a significant number of the 30 high TB HIV burden countries are already in the refugee hosting and humanitarian settings. And so again, these are low middle income countries that are also grappling with constant outbreaks, conflicts, economic strife, socioeconomic issues, climate-related issues. So there are also the countries with high TB burden, also the countries hosting the huge number of refugees and also trying to ensure that refugees are included into the health system. Next slide, please. Dr. Hannah already briefly pointed out some of the barriers that refugees face in terms of TB care, but I just thought I'll flash out a few other points. She spoke about legal and administrative restrictions. These are some of the issues that we face in refugee settings. Fear of deportation and discrimination. I mean, when it comes to HIV or TB, sometimes some governments might deport refugees and migrants, and they are more at risk because of very restrictive policies. Again, during displacement, because of interrupted services mobility, high mobility movement, flight, conflict related issues, security issues, and disruptions to health system, health infrastructures. So these are all the different elements that add extra barriers to refugees and migrants. And of course, language, cultural barriers, and the different borders in different countries have different access and variable access to health services. Next slide, please. Again, spotlighting what was already mentioned, refugees and migrants, specifically in humanitarian settings, they have poor living conditions. Currently, a lot of cuts to the aid, access to health services disrupted, services are already disrupted, variable levels of services are available, risk of treatment interruption, crowded, poor living conditions, malnutrition, undernutrition, and food security high levels due to also accelerated and exacerbated due to the current situation in terms of funding. And of course, a lot of health services for refugees have also been interrupted. Next slide, please. We've recently produced a report to look at some of the spotlighting in terms of what is the impact of the current reduction in aid in the humanitarian sector. And this is specifically on UNHCR and how, at a glance, look at the different sectors and how much cuts have impacted our programs. There you would see on that one of the images, about 35% of cuts have been impacted on health programs in our global operations in over 63 countries. So these are also not only impacting, TB, health, HIV access, but it just increases the protection risks for refugees. And then it also obviously undermines all the progress and hard-won progress that we've made so far. So those are some of the risks. We've made, excellent progress with our health metrics for refugees, extensive TB programs, HIV integrated through integrated sexual reproductive MHPSS approach. But right now, all of those progress is at risk of going backsliding. Next slide, please. So some of the approaches that UNHCR takes in terms of the public health programming for refugees, we use an integrated approach, as I already mentioned. It's not fragmented. It's through universal healthcare, through the primary healthcare approach. So we have a integrated service where it's not only just TB, but it's TB, HIV, STI, and other conditions, along with reproductive health, referrals, and MHPSS included for TB programs. We want to make sure that our approach is also to protect the essential services in humanitarian settings and to ensure that enough financing is also put into TB programs. We have also worked through catalytic partnership, which I will speak about later in the other slide in the presentation, while we work with the different sectors and the different agencies to pool the resources together. And we work very closely with the communities because they are part of our systems and approaches and interventions. And of course, strategic investment into TB metrics. This is really something I think we'll also talk a little bit about later in the other slide. This is an area where we really need to sort of engage and maybe put more effort in, because when the funding cuts happen, and they will continue to happen, our priority will be to target what is really immediate and urgent, and the needs are really high. There's going to be a need also to have strategic investment to make sure we safeguard some of these metrics and some of these policy areas. Otherwise, we might lose some of the data that we might need in the future to advocate. So without data, we can't really advocate. And without that, we can't really move an investment case forward. So these are really some areas that, could potentially be affected that we need to look at and broadly and also pay more attention to. And of course, working through partnership, maybe to fill those gaps in. Next slide, please. So these are some of the ways that we work together, and Dr. Monica already spoke about this. These are some of the products, core products that we have created in partnership with CDC, UNHCR, and WHO. These are practical guidances that we make sure that we follow through in some of our programs. It provides practical examples, advisory and commentary to the managers that are in the health programs. So these are some of the key products that we use in our refugee settings, and of course, and to ensure that TB care and prevention is integrated and is featured and it's not working in fragmentation. Over to the next slide. Here, as we spoke about collaborating for impact and talking about multisectoral partnerships, so I wanted to bring us, wanted to present a case study from the Eastern Horn of Africa and Great Lakes. So this is a partnership between UNHCR, the IGAD. IGAD is the Intergovernmental Authority for Development that covers a few countries. Those are some of the countries like Kenya, Ethiopia, Djibouti, Uganda, South Sudan, Sudan. Eritrea is also part of it. And this is a Global Fund grant TB project. So a grant went through a 3-cycle approach between January 2017 to March of 2025. So it just ended. So the 3 cycles looked at the different levels of scale up. One was to scale up HIV and TB prevention, care and treatment and support services. And the other 2 cycles looked at focusing on strengthening capacity for TB MDR, TB HIV diagnosis, service provision, in-country support and cross-border collaboration. And so this project has ended. It was worth 23.9 million and looked at targeting those countries, Kenya, Ethiopia, Djibouti, Uganda, South Sudan, and Sudan, who host large numbers of refugees. And again, these countries are also high TB HIV burden. They have limited diagnostics. So some of the 3 cycles and the 3 interventions was to strengthen, scale up the diagnostics, like gene expert, laboratory support, training of the lab technicians, and increasing supply chain for the medication, because these countries have variable health systems and variable levels of infrastructure that can support and include refugees as part of the TB program. Next slide, please. So we used a multisectoral approach, which worked with health, protection, communities, and governments. As you know, UNHCR is a protection agency. So we worked with the protection, worked closely with the communities because those are our links and networks. And we also worked with governments. So not just that it's fragmented. So we included through the 3 cycles and the 3 interventions, active case finding, working with the community health workers, training large numbers of community health workers, enhanced diagnostics as we invested in the investment plan that was to scale up the investment in the peripheral health centers. So while we were looking at expanding scale up for refugees, but there were benefits for the host communities because we were improving the infrastructure of some of these primary healthcare. So it targets host refugees and everyone. So it was also capacity building, and we had policy dialogues, partnership, cross-border surveillance, advocacy, and health declarations. So I wanted to touch base on the previous colleague, Salome, who asked about different countries have different treatment, medicines, and etc. So this is where the policy dialogue and partnership at cross-border surveillance and health declaration was to make sure that these countries that are targeted are a pool of countries that are part of the IGAD, so they talk to each other. So, align a little bit the way we look at TB and the TB treatment, especially for mobile populations. So I just wanted to add that element a bit to ensure that there are dialogues and cross-border and regular IGAD meetings that try to look at the synergies of treatment and continuity of care and the continuum of care for TB patients. So some of the outcomes was, again, improve scaled up investment, gene expert, diagnostics, improve community awareness, increase in TB notification rates, improve coordination, functional cross-border coordination, inclusion into the policy framework and programs. So some of that also takes into consideration that these interventions and outcomes work closely with the communities, and that's the community centrality for TB-centered TB care. So, I mean, community are part of our approach, though. So we've worked with the community, the refugee community, and the host communities. So it's enhanced case finding, not only for refugees, but it also benefits host communities. And there are TB champions, targeted interventions, especially in hard to reach refugee villages, mass TB screening during campaigns, again, capacity building of the community health workers that link the community referrals into the health facility. So just bridging those links. And then, of course, while we do TB, we do other areas of work as well, which is TB, HIV services, including sexual and reproductive health and MHPSS, counseling, examples of some of our primary healthcare in the TB is like small peer groups of people with TB, HIV that support each other, mothers group, kitchen groups, solidarity, coming together groups. So these are some of those small pockets of interventions and community approaches that keep people adherence, especially refugee adherence to treatment, refugee adherence to, sharing, because there could be some refugees doing very well and some not, and then this is how they have like a support network to encourage each other, because motivation is also important, especially in communities like this during hardship. And of course, an inclusive community-based workforce that also works with the ministries of health in the small peripheral areas. So we try to connect them to ensure that these refugee volunteers or community workers are included in the MOH training as well. So expand and then it vice versa, increase the level of capacity also for the ministry staff. Next slide, please. So what is the path forward? I think the path forward, as I already mentioned, we need to make sure that refugees, migrants that are crossing borders, regardless of whichever situation, the continuum of care is very important. This is an example of a small, partnership in EGAL, but we would like to see this, sustain beyond 2025 or in the future, moving resources to ensure that these, refugee and migrants in this specific area continue and to have adherence and to have access to TB treatment. To strengthen the multi-partnership, which I already spoke about earlier, the call for action is that we need to work closer together. We need to understand better where the gaps and voids, because the humanitarian sector is also changing and the change is being pushed due to investment. So while we see the investment is lacking, time is almost up, but I will just have one more point. We have to continue the engagement. So these kind of platforms are an important engagement to check and balance and see where we are in terms of implementation, where we need to put our resources together, advocate with the governments, and that governments need to be part of the dialogue. We need to have that dialogue, but the refugee communities and the migrant communities also need to be in that dialogue. So we need to set that stage and that opportunity. And lastly, very important, as I already spoke about earlier, investment into data is extremely important. The data-led programs are really important. Without specific data and investment to safeguard the existing data systems that we have, we are going to lose oversight, and we are going to lose data that might affect the way we move resources and mobilize resources in terms of TB for refugees and migrants. So I think data-led and investment into data is equally as important as we look at the broader TB approach. I think I will stop there. I didn't realize 15 minutes goes very fast. Thank you very much.
Yes, Maheshwari, thank you so much for your presentation and for sharing this important information on how UNHCR supports refugees and displaced people affected by TB. So let me gently remind everyone that you are welcome to ask questions to any of our panel speakers during the dedicated Q&A session after the presentations, or you can type them in the chat as they come to your mind. And also please indicate the speaker to whom you are addressing your question. So thank you once again, dear Maheswari, and we will now move to the next presentation, which will focus on the International Organization for Migration, practical approaches to providing people-centered TB treatment services for migrants and refugees. So it is my great pleasure to hand the floor to the Alexander Arnikov, Senior Program Officer, Health Promotion and Assistance at the IOM. Dear Alexander, the floor is yours, please.
Thank you very much. And I will really try to keep the time before the music starts, but in any case, yeah, that was a really nice surprise, and I like the approach. So anyway, thank you so much for inviting me and giving me an opportunity to be part of this interesting discussion and panel. My name is Alexander Arnikov, and I represent IOM in this occasion. So I will start immediately because the music will start soon playing. So please, next slide. TB is still a major global health issue, and what's important to keep in mind is that TB isn't spread only across the world, evenly across the world. I mean, it's concentrated in a handful of regions where health systems are under pressure, and that's where many migrants and refugees are moving through, and also where some of the social determinants of health are working in favor of TB. But before I move on, I want to remind us all that there are currently around 250 million people on the move, international migrants, and there are like around 700 million internal migrants, 70 million IDPs. So this is roughly 1 billion people, or 1/7 of humanity on the move. So when people are on the move, everything that usually supports good healthcare becomes fragile, and this is like legal status, language, money, the ability to stay in one place long enough for diagnosis and treatment. All of these things get disrupted. Even when countries have decent TB programs, they're usually built for people who stay put. So migration systems, on the other hand, aren't designed to manage long-term treatment needs. So people end up caught between the two. That is what we mean when we say migrants fall through the cracks. It's not about individual behavior. It's about systems that not necessarily may line up. So the result is late diagnosis, interrupted treatment, and preventable deaths. Understanding this gap is the first step towards making TB services responsive to people who are moving, and not just people who are already settled. Next slide, please. When we talk about IOM's role in TB, it's important to remember that IOM isn't a health authority. We are a migration agency. Our work sits right at the intersection of mobility, borders, and health, which gives us access to people and places that national TB programs often cannot reach on their own. And because we operate in so many different settings like humanitarian crisis, mixed migration routes, labor migration, resettlement programs, etc., we see where TB risks emerge along the journey. That puts us in a good position to connect the dots. So we are not trying to replace national systems. Our job is to make it easier for migrants to reach them. In practice, that means using the tools we know best: mobility mapping, cross-border work, community engagement, referral systems, partnerships with local authorities and NGOs. These are all migration management approaches, but they create the conditions for good TB services. In a way, we act as a bridge, helping national TB programs find and follow people who would otherwise be invisible to the system. Next one. So when we talk about people-centered TB services for migrants, we are basically talking about making TB care fit the reality of people who are on the move. So it starts with access. Services need to exist in the places migrants actually pass through or rely on. So this means border points, work sites, shelters, clinics in migration hubs. If these services are too far away or too complicated to reach, migrants may not even use them. And we all know that this may not having services that are not accessible is also changing the health seeking behavior. But also access alone isn't enough. Care also has to feel safe and respectful. That means language support, staff who understand different cultural expectations, and an environment where people aren't judged or turned away because of their nationality or legal status. So if this experience is intimidating, people simply won't come back. So this is, again, can't stay in one place for months. So their work schedules are unpredictable. Their documentation can limit where they go, and they may face protection risks. So services need to adapt to those constraints instead of expecting people to fit into a rigid system. And finally, TB care has to be continuous. Diagnosis, referral, treatment, and follow-up need to work even when someone crosses a border or moves to a new job site. Without that continuity, people end up starting treatment again and again or dropping out completely. Next one. So, TB in migrants isn't only a medical issue. It's shaped by the conditions people live and move through. So, crowded housing, unstable or risky work, detention, lack of documents, long travel, low income. These are all factors that drive TB risk, but none of them sits only within the health sector. Migrants also interact every day with people who aren't health providers, but who have huge influence on whether they can access care. And this includes border police, immigration officials, employers, recruitment agencies, camp managers, shelters. These actors often decide who can move, who can stay, and who gets referred. So they are the gatekeepers, basically, whether they realize it or not. So the challenge is that health teams don't control these spaces. So if TB services depend only on clinics and hospitals, we miss people entirely. That's why multisectoral solutions matter. When health teams work together with migration authorities, labor sectors, protection actors, and employees, those same control points along the journey become opportunities to offer information, screening, referral, and support. Next one, please. The first approach is to build TB services into the migration processes that already exist, rather than creating something separate or parallel. Migrants go through many formal steps. For example, our health assessment programs offer pre-departure checks, resettlement procedures, labor migration screenings, return and reintegration processes. These touch points are predictable, structured, and already part of people's journeys, which makes them ideal places to offer TB information, screening, and counseling. By working this way, we're not asking people to navigate an extra system, and we're meeting them where they already are. But this only works if it's aligned with the national TB program. So we coordinate closely with the Ministries of Health to use the same protocols, reporting systems, and referral pathways. In short, we use routine migration processes as stable entry points, and national TB programs provide the clinical backbone, and together they make it much easier for migrants to access continuous TB care. Next one, please. The second approach focuses on meeting migrants where they actually live and work. So many people on the move do not interact with formal health systems regularly, but they do rely on their own networks and trusted community figures. That's why community outreach and peer-based models that we employ are so effective. Working with community health workers, peer educators, and migrant leaders and networks helps us open doors to a clinic, doors that are clinic alone cannot. So in practical terms, this means bringing TB information, stigma reduction, and simple symptoms check into the places migrants already gather, like camps, informal settlements, busy urban neighborhoods, workplaces, markets, transport hubs, etc. But outreach only works if it connects to real clinical services. So we link soft entry points like awareness sessions or symptom screening to hard entry points such as labs, X-rays, units, and treatment centers. We also offer, we use enablers like transport vouchers, flexible clinic hours, or social support to help people stay in treatment. So small adjustments like these make a huge difference in helping people complete therapy. Next slide, please. As my colleague from UNHCR mentioned, data is absolutely crucial. The third approach is about making our data systems recognize the people that people move. So traditional TB programs were built for static populations, but migrants often cross districts and regions or even borders while they are still in the middle of diagnosis or treatment. If our systems don't anticipate that movement, people get lost and treatment breaks down basically. So we start with mobility mapping tools like population mobility mapping and health border mobility management, displacement tracking matrix. These are all they're giving us a picture of where people travel, understanding better the mobility, where they stop, and where the service gaps are. So this helps us place interventions in the right spot rather than relying on guesswork. From there, the key is building real referral pathways. So points of entry, transit sites, TB clinics, labs, and facilities across borders need simple ways to communicate with each other and with migrants. When one facility diagnoses someone, the next facility should know they are coming. So when a person moves, treatment should be moving with them. Patient health records and maybe interoperable digital tools can make this process much easier. Next one, please. Partnering with health actors, partnerships with health actors is essential because TB care ultimately sits within national systems. Our role is to align with those systems and not create parallel ones. That means following national TB program protocols, using WHO guidance, and making sure that staff are trained in ways that fit the country standards. We also work through platforms like the Global Fund and other TB grants as an implementing partners. I will mention this later in the interest of time, but a big part of the partnership is system strengthening. We support local providers so they can offer migrant-sensitive TB care themselves rather than relying on external actors. So we help improve surveillance and reporting so that migrants and refugees are actually visible in the data. And we pilot small innovations that national TB programs can eventually absorb, scaling them up if they work. In short, the goal isn't to do TB care for countries. It's to help national systems expand their reach so everyone moving through the country, including migrants, can access TB services. Next one. When we talk about TB in migrants, non-health actors are just as important as health actors, sometimes even more. Migrants interact daily with border officials, labor departments, employers, local authorities, civil society groups, and community leaders. These are the people who shape whether someone can actually reach TB services in the first place. So working with migration authorities helps ensure border and reception procedures are safe and health sensitive rather than intimidating or disruptive. Labor and social sectors play a big role too. Without safe workplaces, sick leave protections, or basic social support, it's unrealistic to expect someone to complete months of treatment. Local governments and municipalities are essential partners as well. They can help make TB responses more inclusive. Civil society groups, migrant associations, and faith-based organizations also, they all bring trust and credibility, which is crucial for reducing stigma and getting people. Donors and development banks sustain the whole effort by funding more inclusive TB and health systems. Without that financial backing, many of the interventions that work for migrants simply don't get off the ground. Next one, please. In practice, we are seeing a few consistent challenges. The first is legal and policy barriers. It's not always clear whether undocumented or short-term migrants are entitled to TB services, and that uncertainty alone can stop people from seeking care. Then there is stigma. TB carries its own stigma, but when you add to the fear tied to migration status, many people choose to stay invisible rather than risk engagement. We also deal with fragmented funding, humanitarian money, development funding, and disease-specific grants often operate in separate tracks, which makes it harder to build the kind of long-term inclusive systems migrants actually need. Next one. Our key messages. I mean, if there is one thing to take away, is that people-centered TB care for migrants has to start with their real circumstances, the movement, the work conditions, the uncertainty around status, and the everyday risks they face. When we and then the gaps in care make the approaches we've talked about embedding TB migration systems, working with communities, coordinating across sectors, and planning from day one for continuity of care reflect what migrants actually need. And this is the last slide, and I'm going to wrap up. The next one, please. Thank you. So IOM's TB work isn't limited to a single type of program. As you can see here, we have reached in 2024 more than 1 million people screened for active TB. And this is a lot of it happens through our health assessment programs, which support safe and in development setting and in challenges. Member states fund large parts of the also we are partnering with private sector. For example, we have an interesting project where the Novo Nordisk Foundation supports us to explore how AI can improve TB diagnosis and treatment adherence. So altogether, these different programs and partnerships gives us and I'm sorry that I've been like a few minutes late, more than the music.
It's fine, Alexandra. So we try to be creative and use the element of surprise, a different bell for each speaker.
Great.
Dear Alexandra, so thank you very much for your presentation and for the important work you and your colleagues at IAM are doing to support migrants and refugees affected by TB and for connecting them with national TB program. And your remark once again underlined that one of the key conditions for success in addressing TB and migrants is the consistent large-scale use of multisectoral approach. So thank you again for sharing this experience and please stay with us for the interactive session. So dear colleagues, as we move forward, I would now like to turn to several country-level experience, an example of successful collaboration in the TB response for migrants and refugees. And our first example comes from Western Europe and focus on the practical experience of Médecins Sans Frontières in supporting Ukrainian refugees with TB who have found themselves standard in the Poland following the full-scale war in Ukraine. And according to official estimates, around 7 million Ukrainians have been forced to flee the country 4 years of the war in the heart of Europe. And throughout this period, neighboring Poland has served as a key hub for Ukrainians, whether they remain there or move onward, mainly to other Western Europe countries. And with this context in mind, it is my great pleasure to hand over to Joanna Ladomirska, medical coordinator, TB project in Poland, Medicine Sans Frontiers, to share more about their work in Poland. So, dear Joanna, please, the floor is yours.
Thank you very much, Julia, for this introduction and as well for inviting me and being able to share our experience from TB project in Poland. So I would like as well to say that Poland, it's a high-income country as a host country of the refugee, but does not mean that actually there are much less challenges than in low and middle-income countries that are usually the main host of the refugees. Next slide, please.
Yes, just Jana, as internet connection, so just be in mind that to switch the slide, it takes some few seconds. Thank you.
Okay, no problem. So before I introduce you to our project in Poland, I would like just to highlight the situation of Ukraine to explain as well the context of the refugees that are reaching Poland. As you all know, the conflict started at the beginning of, the full-scale invasion started at the beginning of 2022. But still today, the situation is really dramatic. You can see the numbers of the air raids that has been sounding since the beginning, the incredible numbers of rockets that have been released by Russia in Ukraine. And then you can try to have a mental health, let's say, consequences of this horrible situation that is happening. So you can see in the slide the percentage of the people suffering from PTSD or needing mental health support. So in terms of this context of war, of course, we have the situation of destruction of the medical infrastructure, of course, including the TB care. So as you see in the slide as well, it's incredible high number of the medical facility that has been destroyed or damaged in Ukraine, but as well in terms of the health staff. So not only the people that has been killed, but the people who are burned out or they need to work in the very extreme consequences. In terms of TB situation, so Ukraine, it's a WHO priority country, and it's mainly because of the very high prevalence of drug resistance TB, which is almost 1/3 of all TB cases in Ukraine. And I have to say that despite all this incredible context, Ukraine was able to really respond to the increased needs and adapt through innovation. Next slide, please. So if we look now as well, let's say from the Polish perspective, so knowing that Poland was the main country, as already mentioned by Julia, that received the Ukrainian refugees fleeing the war in Ukraine. So let's have a look as well, what was exactly the situation of TB just before the full-scale invasion in 2022. So I put here in the table the ECDC data from 2021, and you can then compare the number of diagnosed cases in Ukraine, in Poland, and in the whole European Union. And I would like you specifically to put attention to the number of diagnosed drug resistance TB cases in Ukraine compared to the whole European Union and the Poland. So WHO at the beginning of 2022 made an estimation based at 1.5 million of the refugees that at that moment were officially registered in Poland, and they calculated that above 200 patients with drug resistance tuberculosis were in need of continuation of treatment in Poland. And then you can see that it's actually over 4 times more than the total annual numbers of the cases in Poland. Next slide, please. So we already hear in the previous presentation regarding the different barriers that the migrants or the refugees are facing. But so in addition to those administrative or language barriers or for their mobility that it has been mentioned, I would like as well to put this more, let's say, individual part, which we have to understand as well that the health is never a priority for a person that is fleeing from a war. So that as well will indicate the health-seeking behavior. Then we have as well lack of the normal local support system that all of us have when we are for many years in one place. So if, for example, I will have to go to a hospital and I don't have a family member that could take care of my child, and of course I will avoid this hospitalization. But this importance of an existence of a local support system, it's as well crucial. Stigma has been already mentioned, but we have here we are speaking here about the double stigma. So first, it's a stigma related to the disease, and then it's a stigma related to the migration status. And then coming to the context of the Ukrainian refugees, let's not forget that even though those people are crossing the border towards a more safe place, but the war, it's not finishing, that this impact of the war keep on going. They still have loved ones that stay and are at direct risk, and themselves probably they have been as well victim of a trauma. So this as well will for sure affect the health-seeking behavior. I would like just to mention here about the administrative barriers. So actually the Ukrainian refugees, because they receive directly temporary protection, they actually didn't have an administrative barrier towards accessing healthcare, but other migrants they have. So for example, Ukrainians that are arriving since 2014, when actually the war started, they did not have the same facility of access the healthcare that the Ukrainian that reached Poland after 2022. But now let's really look which were the systemic barriers that the Poland at that moment in 2022 had. So first, Poland did not have a systemic approach to TB, so that was not a specific strategy or program or specific resources, and the context was very localized. So each hospital could actually treat patients in a different way, and the guidelines were in place that were really outdated. In terms of the diagnosis, that was not a targeted screening of the refugees. Very limited rapid molecular testing, and rifampicin resistance was not something that was a systematic approach. For drug resistance to be in Poland at that moment, the patients had to stay in the hospital for the entire duration of the treatment. It means almost 2 years hospitalized in isolation, and TB was a complete forgotten disease. This is why that was a lack of awareness, but as well as strong stigma among the medical provider. Next, please. And then we had another huge barrier. We spoke already, many questions were related to the differences in regimens and the medicines, and that was the case in Poland. So Poland did not have the medicines to continue the treatment that were already in place in Ukraine. So Poland was still with the injectable and 2-year schema, while Ukraine already have a full oral shorter regimen. At the same time, Poland didn't have really the fixed dose combination, nothing for children, so no pediatric formulations, and neither rifampicin for prevention. And then we, of course, realized that it was not only the situation of Poland, but it was actually the context of the whole European Union, with the issues of availability of the medicines, that simply they were not there because they were not registered, or they were extremely expensive. And here I will mention the cost of the bipalem regimen in Poland and in many European countries, which can be over 50,000 euros or dollar, which the same regimen can cost much less than $300 through the global drug facility. So when we see this context, we are in a situation where we have a low accessibility and acceptability of TB care, late diagnosis and treatment, so we can see much more complex cases and higher transmission. And of course, if we don't have proper medicines, we have at higher risk of the resistance amplification. So in European Union, high income country, we are somehow disconnect from the achievements of the last decade of intermedicines and standard of care. Next slide, please. So our approach of TB project was first and the most urgently to assure continuation of TB care. So the first really focus was at the provision of the missing medicines. But with all those systemic barriers, we realized that we really need the general transformation of the whole system. This is why it had to be a really joint effort. And it was a wonderful example of really excellent collaboration with different institutions, government, and private sector and civil society organizations, so including Ministry of Health, TB Institute, WHO, who play very active role, and then as well from Ukrainian side, the Public Health Center. So in this joint efforts, what is the role of an organization as MSF? It's really to reaching those which are outside of the systems and making those connections when the links are missing. And then that we facilitate, because we are not in Poland, like in, for example, many other countries where MSF work when we are direct health provider. We are not direct health provider in Poland, but we facilitate the care through the support that we are providing. And then we are able as well to bring this different perspective, which is not a systemic perspective, but this patient reality and humanity, playing as well the role of the fact checker, because even though, for example, by law, treatment of Poland should be for free for everybody, independently of administrative statute, we could see that in practice, this is not the case, and many of the patients need to pay, for example. Being a civil society organization and NGO, we can as well implement in independent advocacy, and we can share our knowledge from the experience from the other contexts where we work. Next, please. So our project, which started in 2022 and just finished now in September of 2025, had several components. The first and the most important one was donation of the needed medicines. Then it was the whole linkage to care through running of an info line, organizing referrals and admissions, being in charge of the transfer out. And this I will speak a little bit later, because we speak about transfer out to other countries. And then we facilitate the clinical history passage from Ukraine towards Poland. And then the biggest part was this whole patient support that include all the social, administrative, and legal support that the patients needed. Of course, mental health support and the whole health education. And of course, capacity building and advocacy efforts. This project has been fully implemented online with a small team of very motivated Ukrainian counselors and with low resources. What we didn't have time to do, it was the active case finding in reception centers, and it was because of the very complicated administrative and legal frame in Poland. We really didn't have time to make, even though it's extremely needed, a campaign regarding stigma and the peer support groups. Next one, please. So as our data, so we are able to support almost 340 patients, from whom majority had drug-resistant TB. And if you see our treatment of outcomes, they were very good. And actually much better for drug-resistant TB, where majority of the efforts were put. And then for drug-sensitive TB, that we see for the government as the next priority, really to as well focus their resources. So as you see, the transfer out, it's a quite percentage, and this I will speak next, please. Next slide, please. So the transfer out to the other countries, as you see, it's over 10% of our patients, because we speak about the mobile population. So many of the patients, and specifically Ukrainian patients, they came back to Ukraine, but not only. They move to other countries inside Europe, but as well much farther. The farthest patients that we link to care, and we really link them to care, were in Seattle in United States, but as well on Java Island in Indonesia. Next slide, please. And who were the patients? So mainly the citizens of Ukraine, but when we realized that the same barriers that were for the war refugees from Ukraine, we as well were supporting other nationalities that were here listed. Our patients were predominantly male, and in terms of the age, they were mainly working age adults, which is different in comparison to the Polish TB patients, which are much more elderly people. We had as well 16 children, from whom 12 had drug resistance TB, and actually the only drug resistance TB cases among children were among Ukrainian children. And then, of course, our migrant patients, they have very difficult social situation. And you can see here in the diagram the percentage of our admissions that have really important challenges in terms of the support system, place to stay after hospitalization, income, and of course, the fact that many of them, they were the sole caregiver. One-third of our patients suffer from alcohol or other substances abuses. Almost half of them experience violence. 1/4 of them experience stigmatization. 1/3 of them suffer from depression, and 5% had disabilities. Next one, please. So as achievement, due to this joint forces, it was really a rapid adaptation. So we were very fast medicines that we needed available on the ground through MSF and WHO donation. We got the new diagnostic tools to being used, so fast molecular testing, implementation of BPAL-M, and management of the price reduction in Poland. So today we have ambulatory drug resistance TB treatment, so no one is staying for the treatment in the hospital. We got those cross-border mechanisms that allow us for the transfer in and transfer out with different countries. Of course, a lot of capacity has been built, and now much more people know about TB. Next one, please. So as a recommendation, we really need to see migrants as a vulnerable tuberculosis group because of their exclusion from the system, but as well of increased risk of transmission and reactivation of the disease. So we really need to find a way to have an active targeted case finding to diagnose people as soon as possible and start treatment as soon as possible. But as well, we need really simplification and self-care. And this was mentioned as well in the initial question. So we really need to have a patient as the main protagonist, and we need those digital tools that will help the patients. We need as well the shortest possible regimen. We have now drug sensitive TB treatment that lasts only 4 months, and migrants should be the target group for this shorter regimen. We, of course, need the holistic approach that has been as well mentioned in the previous presentation. And of course, we cannot think only about the treatment, but as well preventive treatment for the migrant population. And the connections and our networking, it's really crucial when we want to tackle TB care in migration. I really would like to highlight as a conclusion, because very often we stigmatize migration in terms of infectious diseases, but what Poland really showed that arrival of millions of Ukrainian refugees triggered this positive change in Poland, in the rest of European Union, in terms of availability of TB medicines and standards of care. And the last one, so I really would like just to thank everybody. Can you please put the last slide? And especially for the people in Ukraine that go beyond limits, providing medical care for those affected by TB in the times of war. Thank you very much.
Thank you so much, Yana, for sharing the MSF work in supporting Ukraine refugees with TB and beyond. And you are doing truly vital work. And it's impressive how systematically you identify and address barriers to care. And thank you again for your efforts and for this excellent presentation. Dear colleagues, our esteemed speakers continue answering your question in the chat. So please, if you have any question to Johanna, to Alexander, to other speakers, you can continue asking them a question in the chat, and we will ensure it is answered either in the chat or during the Q&A session. So we will now move from European context to Asia, and it's my pleasure to invite Dr. Muna Maslamani, Senior Infectious Disease Specialist from Qatar, to present an
and sorry because it was for me a short note, a little bit about our Communicable Disease Center. It's a hospital facility. It's a regional first of its kind, a specialized tertiary hospital. It's looking to the all, mainly was built for tuberculosis, but also we are admitting cases related to the infectious disease. CDC, it's also like first line of defense on the communicable disease for state of Qatar, advising and supporting the government of the state of Qatar on disease surveillance, epidemiology, and control. Date of opening was October 2016, located in the central of Doha, bed capacity around 65 beds, single bedded, negative pressure room. It's under tertiary hospital group. Also, it's accredited by Joint Commission International as well as person-centered care. We get the re-accreditations related to this facility again for achieving gold recertification for excellence in person-centered care, along with the distinction for leadership and innovation, focusing on the leadership, compassion, and innovation related to the person-centered care, because we approach and breaking the barriers, we engaging our co-stakeholders related to the Ministry of Interior under the umbrella of Ministry of Public Health and WHO, country office and regional office. We approach the prisoner to check on them on tuberculosis, STD, hepatitis B, C, and HIV. Our goal is to continue to deliver the highest quality of compassionate and individualized care through a multidisciplinary approach, and we pledge to continually work with the patients and their families to advance the care we provide to the next level with the same passion, commitment, and experience that have to expected. Of course, we have also mission and vision and related to our facility. So going back to them, our migrant and refugees, Qatar TB program targeting high-risk migrants population through pre-arrival screening, and especially those who's coming from high endemic area. And we have also introduced a comprehensive diagnostic approach, including PCR and whole genome sequencing. Later on, I will talk about it. And comprehensive care is provided at Communicable Disease Center with the free treatment. We apply and to introduce video-supported adherence. Later on, I will mention that, and WHO recommendations, medications. I will talk a little bit about our own incidents and WHO milestones. The WHO set a milestones of 55 TB cases per 100,000 people for 2025. Qatar has constantly stayed well below this target, with the highest incidence rate at 41 cases per 100,000 people in 2002, and the lowest at 20 in 2016. And in 2024, the rate further declined to 23, confirming that Qatar is well on a track to meet or exceed the 2025 targets. This success reflects robust public health intervention, including early detection, efficient treatment protocols, contact tracing, and community outreach to the care transmission of tuberculosis in a growing diverse population.
Dr. Mona, can you speak a little bit slower, please, for the translations?
Okay,
Thank
sure.
you. Sorry.
So, unrelated to the TB incidence rate by nationality in Qatar, you will see that, as I mentioned, it's non-Qatari around 98% compared to the Qatari, which is around 2%. If you see figure, the red one, which is Qatari, the blue one, which is non-Qatari, so almost like the non-Qatari above 80%. So active TB cases diagnosed as well, if you will and if you will see the trend, it's, people may have been more, we are more proactive in seeking medical attention and getting even tested of tuberculosis across the years. And especially if you will see in 2021 was high due to COVID-19 pandemic. That's why the number was like reported because there's a delay maybe. We are focusing all worldwide focusing unrelated to the COVID-19 rather than tuberculosis, despite we spare a good place and attention to our population unrelated to the tuberculosis. Why it's not moving? Okay, so if you will go back to see, we have almost 44%. It's a bacteriology confirmed TB confirmed to the extrapulmonary TB, which is around 51%. And we have MDR and pre-XDR around 0.01%, and death is around 3%. If you will see, comparing male to the female, and Qataris, male equal to the female, but for non-Qataris, which is non-national, which is like 75% male to compare to the females. TB drug resistance, it's variable across the years. And the number of reported MDR cases in Qatar has remained relatively low, but fluctuated over the years. From 2009 up to 13, cases number were mostly between 0 and 6 per year, indicated sporadic detections. And this pattern suggested intermittent challenges in MDR-TB control, possibly linked to the imported cases, treatment adherence issue, or even diagnostic improvement over time. So the recent uptake underscore the need of continuous vigilance, strengthening of drug resistance surveillance, rapid molecular testing, and strict adherence to the treatment protocol to prevent further spread. So going back to what we did related to, cross-border collaborations in TB care, of course, what we did that Qatar National TB Control Program has implemented screening procedures on collaborations with the medical centers operated under of Ministry of Public Health and also Ministry of Interior and also, WHO regional office as well as country office. All of them, what we did that Qatar approach of screening these immigrants before entering to the country aligned with the WHO recommendation of facilitating early detections and, prevention of tuberculosis spread within the country. Those migrants who are not from the certain countries that already, because we open an office aligned with them outside Doha country, outside on their countries. So those who don't have those offices aligned with our own Ministry of Interior upon entry of Qatar, we are doing for them within 1 week or from the arrival, medical commission, they will do complete testing. Another comprehensive referral pathway, what we did, we developed, this is, if you will see the slide or the figure up, this is Afghanistan refugees. We put them in a very nice villas and compounds, and we developed a pathway. Once they approach us, of course, IMO, International Migration Office, with the CDC USA under the umbrella of Ministry of Public Health, Ministry of Foreign Affairs, Ministry of Interior. So we developed a pathway between Medical Commission, Ministry of Public Health, CDC, Ministry of Public Health, and CDC HMC. developed another pathway between IMO, United Nations, and National TB Reference Lab, because we need to get the diagnostic, and how once they were suspected anyone who has symptoms of tuberculosis and related to the refugees, we assign a hotline for them. They will communicate direct with us and direct to the lab to send the specimen, because we need to have all of them. They need to have equitable, fast access to the healthcare. We develop pathway between IMO, United Nations, and CDC, HMC, as you know, appointment system, follow-up for our patients, and prescribing medication. Developed another pathway between a private sector, CDC, Ministry of Public Health, and CDC HMC through National Command Center for transferring patients across the Qatar. So once we will identify anyone positive from migrant or refugees, they need to call our ambulance to come to take the patients in case if he's sick and suspected tuberculosis. Developed fast-track access to the TB patients at CDC, HMC as a walk-in as well, because some of the patients, they will be referred directly from the Medical Commission MOCAM. This is a process map for our own with the, we call it pathway for our diplomatic guests, refugees from, the camp itself through IMO, International Migration Office, to the Communicable Disease Center.
Dr. Muna, sorry, for the French translators, it's very difficult to keep your speed. So if you can just, I know that when you're excited, everyone is speeding, but can you please just slow down a bit? Because for French participants, it's difficult to understand your example. So our aim is to understand. Thank you.
Yeah. So going back to the key aspect in TB care, so video direct observed therapy. What we did in video direct observed therapy, and we invent this one, to be honest, during the COVID-19. So during the COVID-19, we could not accept all the patients, they will come as a walk-in because it was pandemic. So what we did, we have a 3 system in our place before COVID era. That's DOTS, direct observed therapy, which is people, they need to come to our center to receive the treatment. Or we have another team, they will go to the community to give the medication for those who has positive as a follow-up on daily basis based on their workplace. Or sometimes those kind of immigrants that are working in companies, they have a camp and they have a polyclinic, so we'll handle those medications to the polyclinic, or we will go to the patients themselves to give them medications. Or electronic dots, it was converted during the COVID-19 because it will be safe for our patients. So we have 3 ways. But later on, after the COVID era, what we did, we converted slowly our patients to the video dots, and we call it shared decision making. So we are taking the opinion for our patients, which system it's, fits them and more comfortable for them, because even we don't want to bribe them from the work, they are coming every day to take the medication. So this is like a simple example. And don't forget, we are a small country. We can control our TB. We have national TB program. We have national TB registry. That's why we know every single TB in the country. This is Video Dots team helping us to assist and to communicate with the patients and do registration. And those our own nurses, we need to maintain our privacy and confidentiality. And this is when we did the training for them, especially how they will do electronic health system related to the video dots and how we will do migrant. By the way, the migrants, the main problem that in the middle of the treatment, they will leave us. So they will take the medication because it's free as well. And we need to inform their country through Ministry of Public Health, IHR, that they are deporting Qatar or they leave in Qatar. And we are trying to hold them till they will finish the treatment. But some of them, they prefer to go back to their country. For us, we need from them to stay because we need to be sure that they completed their treatment complete course. So once they will leave, what we will do, that we will communicate with them through video dots. So what I know that the time maybe is different, but as much as we can, we are affording them, okay, we will help and support you. Also, till you will get access there in your country, we need to monitor you. And this is all the phases or video dots. It started when and end when. And this is, we developed a process map for the video dots, especially for our populations. And we are putting a KPI to monitor even the compliance and related to these medications. What about advanced diagnostic and treatment protocols? We have a national TB reference lab. And the National TB Reference Lab, we introduced a PCR, whole genome sequencing, and culture-based test within our own CAB accredited TB lab. We introduced also TB drugs, second line, like bedaquiline and protonamide for MDR, and it's free. I know that, as my colleague, she mentioned from Poland, that it's very expensive. I do agree, it's so expensive, but we introduce it for MDR. This is equitable for everyone. Again, then the tuberculosis in our country, above 95% non-national. Despite this, it's a free, of course, diagnostic free, everything for them free, because we need to maintain the safety and community issues as well. So these resources are funded by the government, and there is no discrimination for the healthcare facility offered either for refugees or migrant. We have all that type of anti-tuberculosis and related of medications once weekly, 3 times per week, or Rifampicin, rifampicin, all type. Key aspect in TB care, multidisciplinary and holistic approach. CDC TB program bring together all multidisciplinary team of healthcare professional, nurses, doctors, dietitian, pharmacists, social worker, to provide comprehensive holistic care for this migrant population, including social support and psychological support. So our team of healthcare professional from different, even our team as a healthcare from different countries, by the way, that migrant patients receive culturally sensitive care with no language barrier, as many staff members speak the same language as the patients. It's our own team. We are celebrating, even if you will see in the slide, with TB patients. Prevention, treatment, and infection control. Qatar actively screen individual, including healthcare workers, resident in correctional facilities, and the close contact of TB patients, providing appropriate TB treatment. Awareness campaign and community education to overcome the stigma associated with the infectious disease. CDC, what we are doing, we are doing, under the Qatar TB control strategy, we are conducting a public awareness campaign targeting labor camps, providing educational material in multiple languages, including Urdu, Arabic, Hindi, any languages. Annual TB campaign promote, always we need to educate the public how to detect that TB early. This is, if you will see the slide, our physicians celebrating with our tuberculosis patients, celebrations. We engaging them. This is part from our person-centered care. It's not isolated in the room. They need to be in the balcony with us. We will wear masks. They will wear masks. We need to communicate with them. Environmental, it should be well-being for them, and wellness program as well for them. If you will see the other slide, that's mean art therapy for our own patients. So this is all we are engaging our TB patients in our system, and how we are making them happier, healthier. And after discharge, we are engaging them in our sport activities as well. They will become like, advocate for TB in the community and advocate with us for our TB patients. Innovation and expansion plan to overcome TB among immigrants. Qatar TB control plans to expand TB infection screening, because this is part from WHO recommendation we need to do for high risks. We are doing, but it's not all for high risk. We need to go back to see our resources, lab capabilities, everything. So this is our plan. Additionally, Qatar plan to use line probe technology to understand the dominant strain of TB bacilli and epidemiological distribution as well TB clusters in Qatar, and this will help also eradicate TB and support WHO goal of TB elimination. This is some of the research that we did in TB, and we need to do more, to be honest, because we have a lot of related to the tuberculosis, a lot of patient screening knowledge, a lot of data and information to share it with the other countries as well. Thank you.
Thank you. Thank you so much, Dr. Muna. Thank you very much for your clear and insightful presentation and for sharing Qatar's experience. And as you showed, there were a lot of marks. People were marked and upload your presentation. Thank you for sharing the Qatar experience, basically in addressing TB among refugees and migrants. And your interventions highlight both the challenges on the ground and the very practical solution that can be implemented. And we will now move from Qatar to one of the world's largest humanitarian settings. It is my pleasure to hand the floor to Akramul Islam, Senior Director, BRAC Health Program, to present BRAC's work in Cox's Bazar. The Cox's Bazar district in southeastern Bangladesh hosts the largest refugee camp in the world for Rohingya refugees from Myanmar, home to hundreds of thousands of people who have been forced to flee discrimination, violence, and persecution. So, dear Akram, please tell us more about your work on TB in Cox's Bazar. Thank you so much. The floor is yours.
Thank you so much. Yeah, thank you so much, Julia, for inviting me and then also sharing experiences. So I will try to be slow but also mindful about the time. Yeah. But the next slide, please. As my colleagues from the unit shared, and also Julia mentioned that the Cox's Bazar is one of the crowded slums, crowded refugee camps. And in Cox's Bazar, particularly more than 1 million refugees came from the Myanmar. And this is about 8 years. So it's quite difficult to maintain these camps, providing different services, not only for TB, but overall health services and other services as well. And as we know, the prevalence of the TB in Myanmar is quite high. And we believe that the prevalence in the Rohingya camps perhaps more than that, because most of the people are staying in one single room by every single family. So they don't have enough space to sleep and stay and live. So it's quite crowded, and you can see the room also is dark. So it's quite, if anyone has a TB, it's very easily to transfer it to others. So it's kind of a big challenge for us for improving the living conditions, which is very much needed. However, in Bangladesh, as BRAC basically responsible for managing the tuberculosis, HIV, and malaria in the camp and integrated manner. So we basically work closely with the national programs and other UN and NGOs. The TB is not alone a single delivery mechanism. We do it with the primary healthcare services along with other services. So from the beginning, it is together with the Ministry of Health, together with the UN and NGOs, and also the integrated manner that we deliver the services. The next slide. Total is about 33 camps in 2 sub-districts. It's about, and I told about 1.1 billion people actually staying there. And we have 5 primary healthcare centers with the 2 gene expert machines that we provided. You can see in the bottom, the primary healthcare centers, one of the primary healthcare centers. But also we have 2 mobile diagnostics vans with X-rays and gene expert facilities. So these vans also moves within the camps on a particular time and day. So people know this van will come here. So the presumptive people or people with TB symptoms, they will come and have the test. So this is the way basically we try to bring the services closer to the household of the camp, inside the camp, but also people can come in the private healthcare center established in the camp. And in the camp, there is a few around 40,000 Rohingya refugees also be transferred to another island, which is called Bhasanchar. So we also established gene expert facilities along with the one microscopy laboratory. So we tried our best to basically expand the diagnostic networks with modern technology, with gene experts and digital X-ray, and placed in the primary healthcare setting so that we can integrate services in the primary healthcare settings. In private healthcare settings is not only this maternal child, it covers a wide range of services. It's all health, also in mental health, gender-based violences. So you see the kind of the care that needs after the any violences. So you see the care that we covered quite bigger range, including the nutrition that we are having. As you know, in the UN sectoral system, nutrition and health is working separately. But for us, basically, we advocates for the nutrition and health to become closer, mental health come to be closer. So it's kind of one-stop service delivery model that we promote in the camp. Next. And as I talked about the approach, how we do it, So we have our community health workers in the camps. So they mobilized house to house the people, checks not only for tuberculosis, but any other illnesses, including the identifying the pregnant women, non-communicable diseases, all of the issues, to some extent, the child protection issues that come from them. So they do, and also the domestic violences. So they do reports to the facilities in the particular linked up with the respective sectors. And for the TB, if they find someone to be the symptoms, they basically hand it over to the sputum containers to come the sputums in the centers, or they go to the mobile camp that they have it. So in this way, they mobilize the community, provide the information to the community, and also provide the basic tools that there's need to collect the samples from there. And this samples again then transportation to the laboratories, where the laboratories are placed either in gene expert sites or microscopy site or the X-ray sites, and then be tested there. So this is one way that you can see the approach of community awareness through the household, at the household level, by mobilizing people at the community level, but also transferring samples, collecting samples to the laboratory for testing, so that the people can have early testing, along with the facilities that I have shared earlier. Next slide. Yeah, so once the diagnosis happens, those laboratories, as I talked about this, the different facilities that we have it, so once the diagnosis happens in these facilities after, then we start basically treatment. And treatment supervision, basically, we do rely on the community leaders or the community health workers. It depends on where the patients feel more comfortable, either with the local, the community health workers, or the beliefs in community members or the community leaders. So we give some sort of flexibility here so that they can choose their providers that they can support inter-treatment period. While our field staff, the monitor the treatment adherence and any side effect that they have it. If they don't have it, it's fine. But if they have it, they basically advise them to come to the health facilities to meet the doctors and get the advices for that. So this is the way that we can make some flexibility within the system, where the people has a choice, the patients has a choice where they can get these services, either their home or with the family members or the local leaders or the community health workers. They can even choose even the health facilities sometimes, because health facilities is not very far from there. So we give some sort of, kind of independence to them after having strong counseling, It's not just leaving them their own choice, but we do a counseling that you need to be taken care of at least for the 6 months to be continuation of the treatment for every single dose of the medicine. So you really can't stop it. And if you have any side effects or any kind of adverse effect, please come to the facilities, come to the doctors, so that you can get a qualified doctor's advice there, and then you can get better services there. So there's a way of flexibility is as you know, this the refugee settings people is not just only this health issue. There's a lot of hopelessness out there, and the people doesn't see their future quite well because they lost all the asset that they live with. So it's not that you force them to do it, it's really a kind of a good counseling to know to choose their own appropriate process that they require it. So that's why we give a lot of dignity. We try to make it more dignified way of living for them, dignified way of choosing their requirements. So we do a kind of full respect to them, but choosing for themselves. But of course, with a strong counseling that we believe to do it actually. The next one, please. Yeah. So as you know that, so one of the big challenge also with caring these people also big challenge. So we provide some supports to as an incentive if they can continue the medicines there. So that's also being built. So if it's particularly if there's community health workers, community volunteers, they get some incentives for the supervising these patients for entire 6 months. And this incentive, they get it when these patients declared cured, both in drug sensitive and drug resistance cases. So that is built in the system. So you see some sort of relationship between these providers and the recipient, but also they have been incentivized so that they can get some motivation to provide the care properly. And that will also have an accountability, because when you test the follow-up test, if it is not being recovered, so they will not get it actually. So it's kind of way of some accountability to the refugees also important here, because we are committed to do some things so we are accountable to them to provide services. As I talked about this, so integrated, we also have a preventive therapy we provide. So there's also do a kind of a screening, we do it, identify the eligible peoples, and also motivate people or counsel them for preventive treatment as well. So that's also another part we have been doing. Most recently from the 22, we started on that part. And for the disease prevention, not only we trust only the community health workers and volunteers, but we do have other multi-sectoral approaches like the religious leaders, like school teachers. You really need to communicate this information to multiple channels. The people needs to know this, what is the signs and symptoms, what the services are getting, and they'll get support and provide support to the peoples who really get support. So it's kind of a way that beyond the health sectors, as I talked about, the primary healthcare centers is within the multiple sectors that have been integrated. But here is again the community leaders being supporting multiple angles. So we utilize as much as possible with a different way of including teachers as well. So we see as a multiple way of looking at that. But in the context of the refugee settings, sir, colleagues are, IOM colleagues are there, more sectoral approaches, but we do also go beyond that sectoral process to engage more people on particularly the refugee peoples to participate in the process of care and information sharing, the dignified way of taking care, all this kind of. So we try to build their own agency so that they can serve their own community well. The next one. When you say the stakeholder engagement, as I talked about it, the primary healthcare centers is basically is centers for as overall all the healthcare, including some inpatient services, with mental health services, with disability care, with eye care, with the people who have like gender-based violence or domestic violence, they also come for a care. So we try our best to do it. We also linked up with public health hospitals, other public hospitals, government hospitals. So we don't also rely on the private health centers. If the public or the government hospitals are required to provide services, we do linked. We also do linked on other like Red Crescent, MSF hospitals. We do a kind of linked on that. So we did kind of a way of mapping of services, who are providing services within the camp and even outside the camp, because in TB programs, HIV, malaria, all this program is not only tailored only to the refugee populations, Rohingya populations, that is also equally been given to the host communities. So to maintain the cohesions of coexistence, peaceful coexistence, because if we just provide care to this refugee population and the host doesn't get this equal care, so the peaceful coexistence always affects. So we were also mindful for that issue of social cohesion and then peaceful coexistence together. And I talked about it that we do have the collaboration and coordination every month. So we do it with the district health authority, invited all different stakeholders who basically participate with UN agencies to the local NGOs. So we do work on that, and then in this quarterly review meetings, basically we review the performances. We discuss how can we extend support the programs, and very fortunate that since the TB program is a part of the national program at this point, so that is one of the big achievement that we made it. So the government's put this the inter-TB HIV malaria program on the national strategic plan. And then when we mobilize resources, so we mobilize resources for them. So it doesn't need to be separate resources from the UN joint response plan that we have it right now. So it's kind of a way that we work together and then put in the national response plan. Next one, please. Maybe the last. Next slide. Yeah, this is the last slide, so I will be timely. As you said, there's nearly around 2,500 to 3,000 cases every year we diagnosed as a TB. Nearly 40 to 50,000, nearly 50,000 people are being screened. HIV is, test among these TB patients almost nearly around 90%, but HIV among the TB patients is very marginal, around 4 or 5 per year we get it actually, we do also quite a strong case and contract investigation, and eligible people also be enrolled in treatment. So it's kind of 60-70%. You see is out of 2,796, nearly 1,700 got enrolled in the TPT. And drug resistance still is not much because we do a strong treatment adherence protocol, and since we do a strong counseling, we have to do the treatment supervision by the community groups, community leaders, and community health workers. So thus, still the MDR cases quite small numbers, is less than 1%, or maybe around 1% is still in this camp. So I just make it 2 years data, 2024 and then September up to 2025. Treatment completion is nearly over 95%. So you can see this is why the lower rate of the drug resistance, because of higher compliance rate in treatment adherence. Yeah, so that's overall my presentation. Yeah, thank you so much for listening me.
Thank you so much, dear Akram. Thank you to you and to your colleagues for all the support that you're organizing for refugees in Cox's Bazar camp. And basically, your presentation clearly shows how strong and well-structured your collaboration is with both the medical and non-medical sectors, including NGO, and how effectively you are engaging all of them in this work. So thank you once again for your inspired presentation and important efforts in Cox's Bazar. Dear colleagues, we are moving forward. We have 10 minutes approximately. So we have one request in the chat from Pathe Balde. So he asked you, dear participants of our event, to share how do you work with IOM. So if you can share from the national experience how you work with IOM, it would be great. And just a brief reminder, as we have some requests in the chat, that we will share all speakers' presentation and the recording of today's webinar with participants after the event. And if you were not able to join our previous WHO webinars on operationalizing the key steps of MAF-TB, you can watch the recording using the links that my colleagues will now post in the chat. So I would like once again thank to all speakers for their engaging presentation and for the unique experience and insights you have shared. And before we will move to the to the Q&A session, we will be able to hear a few reflection. It is clear that multisectoral dialogue on how different sectors can contribute to the TB response is more relevant than ever. And we would like now to ask you which sectors and areas you would be most interested in exploring in the future MAF-TB webinars. So I'm asking my colleague to display the survey on the screen. And on your screen, you will now see a tentative list of sectors. So Vlada, can you display the survey on the screen?
Yeah,
Okay.
I try. Do you see it?
Yes, now we see it. So, dear colleagues, please select several sectors for which you would be interested in dedicated session where we could share implementation experience and discuss how to overcome common challenges within those sectors. And some of these sectors have already been touched upon during these and previous webinars, but maybe you anticipate that we may need to explore them in more depth going forward. So if you do not see a sector that you consider a priority for engagement in the TB response, you can just please write it in the chat. So I see that people are answering. Great. Thank you so much. It's really important that we have your responses and we can link our future topics with your priorities and your needs. I see that people are still answering. We would appreciate, so you can choose several options for the future MAF-TB webinars. So the topics that you would like to explore more in depth for the future MAF-TB webinars. I see that half of participants already answered it. I see no one is answering it more. So Vlada, I believe we can stop the screen sharing and the survey. And thank you very much. Thank you very much for your responses. We will analyze them carefully and use them to shape the themes of our future events. And as we coming up close to the end of our webinar, we just still would like to have an opportunity to discuss and to reflect on what you have heard and your own experience in providing people-centered care and for refugees and migrants. We have approximately 5 minutes, but if you have any reflections or question to our esteemed speaker who shared their excellent work in supporting of refugees and migrants. So you are welcome to raise your hand and ask question to any of our speaker. So do we have any questions? Because there were a lot of questions in the chat that speakers try to provide a comprehensive answer.
Maybe I can just respond to the questions. How we do work with IOM?
Yes, it would be great.
Yes.
Thank you.
Yeah.
Akram.
No, I think as for Bangladesh and in the Rohingya camps, basically I talked. So we closely working with the UN agencies like UNHCR and IOM. So they have the health facilities. So we do a kind of quarterly meetings together with them, with the district health authorities. So we all are in the same room and we discuss the issues and the problems, So we're quite open of, it's for the diagnosis, it's for the referral, it's for the care. So I don't see the big issue to collaborate and coordinate if we have a good willing, and then if the local government, basically governments, take this more, responsibility for ensuring the care. So that was my experience, and then maybe others may have different experiences.
Yeah, thank you so much. Maybe Alexander, maybe you can share your experience how countries are communicating with you or collaborating with IOM directly through which approaches and practices.
Sure, thanks. Basically, I mean, we have offices in more than 170 countries, and then health-related programs in around 120. So usually we are very well connected with the health authorities, the ministries of health, national public health institutes, and as well in this specific case, TB national programs. And as I mentioned earlier in my presentation, the entire the whole point of our intervention in the countries is to support the member states and not to create parallel systems. Therefore, to approach to IOM or the IOM approaching to the beneficiaries is basically always through the health authorities, and we always participate in multi-agency task force meetings, bodies, whatever exists in a specific country. There is always UNCT, and then we are always participating in these efforts, basically to try to coordinate as much as possible the interventions, especially nowadays. This is very important because the financing is less and less available. So none of us can afford duplication of services. Therefore, coordination is super important. But in case specifically for IOM, usually, I mean, the office is always open for any suggestions and any support that is able to provide to the beneficiaries. Of course, this is always based on the careful analysis of existing gaps. What is the capacity of IOM in that given country, and then it's a combination of all of the above, I would say. So yeah, that's pretty much it.
Thank you so much, Alexander. So, Monica, would you like to reflect at the end of what we heard from speakers and wrap up? Thank you.
Thanks so much. So many thanks to all of you, to all the speakers, the partners, and participants for contributing to today's discussions. We actually had over 135 participants joining. It shows really the keen interest in this important topic on addressing, the importance of cross-sector collaboration and delivering truly people-centered TB care for migrants and refugees. This has been very important. Our thanks to the key speakers, Maheshwari from UNHCR, Alexander from IOM, Joanna from MSF, Dr. Muna from Qatar, and Akram from Bangladesh. You saw firsthand how they have managed to really implement and put into practice the policies on the ground at the country level, at the national, at the regional, and the global level to make sure that refugees and migrants are not left behind. And we see these concrete actions and experiences well reflected today, and it shows how the multisectoral accountability framework to end TB is being put into practice, bringing together different ministries and the UN agencies to address this key issue. I know we are at time, so I thank all of you. I thank Yulia and for excellent moderation, and your team, Alia, Vlada, Leshia. From our team, I'd like to thank E and Anna from WHO as well for the support. Dear colleagues, as we move forward, let us continue working together with governments, civil society, communities, international partners. We're all moving towards one goal to ensure no one is left behind, for health for all, to make sure refugees and migrants especially are prioritized in these times of crisis. Thank you for your dedication and participation. And as we are at the end of the year, best wishes to you for end of the year for you and your family, and best wishes for 2026. Thank you.
Thank you so much, Monica. Dear colleagues, thank you for your participation today and for your active engagement in advancing MAF-TB. And I would like to once again express a deep gratitude to our speakers for the expertise and experience they shared, and to our interpreters, without whom today's multilingual discussion would not have been possible. Once again, we extend our sincere thanks to WHO for its long-standing systematic work and comprehensive massive support in promoting multisectoral approaches to TB elimination. Thank you all once again. We will share all materials and information from today's webinar in the coming days, and we look forward to seeing you again next year. Thank you so much and have a great end of the year. Bye-bye.
Thank you. Bye.
Thank you. Bye-bye.
Happy New Year.
Yes, Merry Christmas and Happy New Year.
Happy New Year, Merry Christmas.